Well, greetings everyone, and welcome to the EKG case for the week of January 6, 2013. Happy New Year to everybody out there. We're going to kick things off this year with kind of a fun case. Before we get into the EKG, though, I'm going to show you a photo and ask you this. What is it that you see when you look at this photo that I got off the internet? Now, some of you may see the Himalaya mountains. Some of you may see snow. Some of you may see in your mind's eye an opportunity to go skiing or trekking. Some of you may just feel really cold when you look at this. Well, I'll tell you, when I look at this photo, what I see is a giant T-wave. Now, maybe I don't get out enough, but I love T-waves. I see T-waves, that movie Sixth Sense, I see dead people. Well, I see T-waves everywhere I look. And I love the T-wave. I love biphasic T-waves, prolonged T-waves, narrow T-waves, short QTs with narrow T-waves. I love deeply inverted T-waves and spiky T-waves. And this is something that I see when I look at the mountains. I see big T-waves. Now, what the heck am I talking about? Well, this photo of the Himalayas is going to become very relevant as we get into this case right now. This case was actually sent by Dr. Mike Slatnik, who is a rural general practitioner who was working up in the Canadian Arctic. You talk about cold weather, but he was working up there, and he had a 24-year-old man who presented to the emergency department with pretty bad diarrhea. He was really dehydrated. He ended up being diagnosed with salmonella gastroenteritis. So this is a major diarrhea problem that this guy has, and no doubt he's very dehydrated, and he's got some major electrolyte abnormalities as well. He was fairly hyponatremic, hypokalemic, probably hypomagnesemic as well. And Dr. Slatnik started out by getting a 12-lead EKG. And what do you know? Take a look at these T-waves. It kind of looks like that photo I just showed you a few seconds ago. Let's go back and take a look at that. That's the 12-lead that Dr. Slatnik is looking at. Well, maybe not. Anyway, with this 12-lead EKG, he looked at these T-waves and thought those are awfully bizarre-looking T-waves. There's kind of a double blip there, but this is more than the camel hump that we've talked about before. This is something that is so bizarre that people actually have referred to these as Himalayan T-waves. Well, Dr. Slatnik looked at this. He called up the cardiologist, who was impressed with the prolonged QT and also the morphology of those T-waves, said he had never seen T-waves like that before. The guy's got electrolyte abnormalities, and the cardiologist simply recommended, well, there is what appears to be some ST elevation, though the guy doesn't have cardiopulmonary type of symptoms. He said, why don't you fix the electrolytes, and then if the ST elevation and those bizarre T-waves persist, then maybe we'll transfer him out here, and we'll take him to the cath lab and find out what's going on. So really bizarre T-waves with these big-time spikes up there and a prolonged QT. So Dr. Slatnik started trying to correct the electrolytes. He started out with a gram of magnesium and repeated the EKG, and the QT's gone down a little bit, and maybe the peaking of the second hump on those T-waves is starting to get a little bit better. And then he corrected the potassium and gave some more normal saline. The sodium came up, and repeated the 12-lead EKG with these better numbers, and now it's looking a little bit better. Still pretty large, tall, mountainous type of T-waves there, but not quite the Himalayan type of spiked-looking T-waves. Very unusual morphology. And anyway, this is an interesting case. Unfortunately, Dr. Slatnik's term during the shift at least ended, and he wasn't able to get any more 12-lead EKGs on this patient. But you can see that this EKG, this is the initial one, and this is the final one that he was able to get as the patient's electrolytes were correcting. Presumably, he went back to a normal 12-lead EKG by the time his electrolytes were completely corrected. This is something that has been referred to in the literature as Himalayan T waves. These very bizarre, very tall, even spiked-looking T waves, not hyperkalemic. I'm not drawing this too well, but hyperkalemic T waves, as you recall, are narrow-based, very tall, kind of pointed on the top, and I don't know what that looks like, but very, very tall and kind of poked at the top. These are kind of a double blip and almost a mountainous. Well, anyway, just to look at the 12-lead EKG, my drawings are pretty horrendous. But again, this has been described in the EKG literature as Himalayan T waves. And actually, it's not only associated with severe electrolyte abnormalities and hypokalemia in particular, but it's also been mostly described as part of a congenital long QT syndrome that's associated with deafness. Many of you will recall that syndrome, the long QT plus deafness, is referred to as the Jervell-Lang-Nielsen syndrome. And the reason that we need to worry about this particular T-wave morphology is that this is highly associated with syncope and what I would probably describe as pseudo-seizures. They're not true seizures, but they look like seizures because patients are syncopizing and having some myoclonic jerks when they syncopize because they're not perfusing the brain. And the reason they don't perfuse the brain is because they go into torsade. So syncope, presumed seizures, all related to torsade. And the key thing here is that whether it's this congenital problem or whether it's hypokalemia, these patients have a prolonged QT and they are at high risk for going on to develop torsade type of arrhythmias. Another healthcare provider, Craig Robinson, who's the trauma care coordinator at North Shore Hospital, as I recall, had emailed me and said that he saw a very, very similar case. The patient's potassium was 1.8, and that patient had what was referred to there as Himalayan T waves as well, T waves that were prolonged and even spiky at the very top. So just kind of an interesting, simple case, a little pattern recognition here. If you ever see these T waves that remind you of a mountain, these Himalayan T waves, really, really tall, very large T waves that are associated. These are fairly tall also, but this is after some correction. But these very bizarre T waves you'll find on the internet if you do a search for Himalayan T waves. This is highly associated with long QT syndromes from severe hypokalemia or from this congenital condition. Beware torsade with those type of patients. And I don't know, I thought that was a fun case to just start the year with and be on the lookout for those Himalayan T waves. Okay, simple case. Next week, we'll go into some more difficult type of things. I hope that was helpful. And if you ever see Himalayan T waves, hey, you've got the answer an hour before your labs come back. Hope that was helpful. And my thanks to Mike and Craig for sharing those cases with us. Talk to you next week.
All right, so we're going to show you guys the basic steps for putting in a transvenous pacemaker. So there's a couple of key things that you need to grab from the central line cart out in front of room 25. The first one is you need the 5 French introducer sheath. Sometimes you'll actually find it in this kit here, which actually has your electronic pacemaker box. Once you've got that, you also need the actual temporary pacing electrode catheter, which comes in this sheath here. So if you go ahead and open these up with your patient.
One quick thing. You don't want to use the 9 French cordis because this is only 5 French and it's gonna leak around in the diaphragm. So don't use one of those. And there's also a pacing swan that has a balloon on it that will help you float it into where you want it if you so choose to use that.
All right. So 2 types of catheters really that you can choose from between these 2 pieces. The first one you have here is this 5 French central venous catheter here without any ports on it. if you're doing this on a patient that you think you're going to need to start pressors on, which is probably most patients that you're going to be doing this procedure on, you might want to opt instead to place this 5 French because it has this medication and aspiration port here. So once you have everything open, you have to do kind of a combination of the 2 kits. The first step is going to be to load your dilator through the diaphragm on the top of here, and it actually clicks onto place like that on the top of the catheter. The second thing you're going to need is you're going to need the needle out of this one to actually place your line under ultrasound guidance. And you can just go ahead and take this catheter off completely if you're not going to use it. Then all you have to do is load your syringe on the end and then place your either right internal jugular central venous catheter or your left subclavian central venous catheter like you normally would using ultrasound or a blind technique or however you're going to do it. Once you've got your catheter in, the next step is the guide wire. This can be slightly tricky because, as you can see, there's that small hole down past this piece of plastic that you have to pass the J-wire through. So you need to start by pulling the J-wire up just to the edge there and then feeding it directly in. If you have the J-wire fully in like that, then you don't get any resistance and you'll easily be able to feed it through your needle, and then you see the J-wire coming out. Once you've got your J-wire in like you would for any central line, you're going to pull the whole apparatus out, be left with your J-wire, make your skin neck, and then you're going to pass your introducer sheath like you would for any cordis insertion. Once you've got that in, you can pull both the introducer sheath dilator and the guide wire out at the same time in one stroke, and then what you're left with is your 5 French cordis that's now placed with your aspiration port. You can suture that in place with the loop here, and then you're ready to go with putting your pacemaker in. One thing to remember about the pacemaker is this wire has memory. So if you're putting this into the right IJ, you need to angle it so that the wire can go into the heart. So as you're putting it in, you want it to be facing to the left, the patient's left, so that it can make that curve towards the heart. If you're going through the subclavian, it's going to be the exact opposite. You're going to want it towards the right so that you can make that pass into the right atrium and down into the right ventricle so the catheter can sit there. Another thing to think about is these wires have little nicks on them. It's going to be hard to see, I think, on the video, but the double nick here represents 20 centimeters. This triple nick would be 30, 40, and then a big black one for 50. Most patients, you're probably going to find your pacer to be properly placed and seated in the apex of the right ventricle somewhere between 30 and 50. So if you get past that, you need to be worried that you might be coiled in the right ventricle, which could be a nidus for clot. Once you've got your sheath loaded and you're ready to insert your pacemaker wire, you gotta first load these ports, and this is where your helper is going to come into play. This negative lead here is labeled distal, and that's the lead you're going to be hooking up to the V2 port on the EKG machine. So you've got your EKG set up like you would with all the electrodes attached, everything but V2, and you go ahead and place these yellow clips on, and then you attach the black clip to the negative lead, leaving the positive lead free floating for now. Then your helper, who's not sterile, clips this onto the V2 of the EKG, and so as you're advancing your guide wire down and keeping track of how deep you're going, you'll see the EKG changes that you're looking for. First you'll see like a CVP reading, like the flutter of a CVP as you're in the superior vena cava. Then once you get into the right atrium, you'll see a exaggerated P wave and then as you move down into the right ventricle, you'll start to see like exaggerated ventricular spike on your live EKG that you're running under V2. And then once you get to the apex of the right ventricle and you're actually irritating the wall of the right ventricle, you get that STEMI looking injury pattern in V2, and that's where you know you've hit the right spot. At that point, you're going to secure your sterile sheath, and then it's time to hook it up to your pacemaker.
That's a good point. Make sure you remember to put the sterile sheath on the line before you put it in.
Absolutely. Once you get your leather bag here, you've got your pacing unit and you've got your cable. Once you pull out your pacing unit, you have both your atrial and ventricular spots up here. You want to plug your wire into the ventricular one. Once that's plugged in, you're going to remove the lead V2 from your EKG, and you're going to plug these yellow clips in. Remember that the distal one is your negative electrode, so you want the distal one to go into the negative here, as you can see.
It might be clamped down.
Yeah. All right. And then the positive end. Clamp them both down on the sides here. Now you're ready to go. On your pacing unit, you turn it on. When it first fires on, you're going to see that the atrial output is set to 10. Since you're not pacing the atrium at all, you want to go ahead and crank that down to 0. And it starts at 10 milliamps with the ventricular output. Up here is where you set your pacer beats per minute. So set that to whatever you like based on the indication of your patient. And slowly titrate this down, watching your monitor until you lose capture. So let's say we titrate it down and somewhere around 1.5 we just lost capture, and now the patient's back in their bradycardic rhythm. Go ahead and just move it 2 clicks up until it recaptures, and you're done. You can leave it right there. So after that, you can adjust your capture or your beats per minute as needed in case the patient's condition changes, but that's all you gotta do.